Thank you. Let's see if I can hold on to my water up here without knocking it over. It's going to be a little challenging. Okay. Well, I appreciate the opportunity. Thank you for inviting me to CSG today. And I want to actually tag on to quite a bit that you heard in the previous comments from Dr. Parks and give you some ideas about even further targeting patients, the subset of the subset of the subset of patients that he was talking about, and how we could even double and tremendously maximize the cost savings and quality improvement. So there's a little bit, I guess, on my bio about state Medicaid experience. We have spent more than 25 years now in the Medicaid policy and claims data analysis work, working on helping states implement medical homes, implement disease management programs, care management within their systems, particularly looking for savings in their systems. Our most recent 5 or 6 states that we've analyzed, I'm going to give you some examples from those. On our website, we have a lot more extensive information. I'm also going to make available all of our background materials for you, for your conference attendees. So identifying the targets. So what do we mean by the targets? Uncoordinated care, and I'm going to explain to you what we mean by that. Lack of appropriate medication use, which you heard about, unmet treatment goals, and avoidable cost. So what do we find in all of the states that we've done extensive analytics? We find a lot of common themes, right? You've heard about them all morning and probably yesterday too. Lack of treatment. We have hundreds of thousands of patients in every state Medicaid data set that we go in and look at where they are incurring hundreds of millions of dollars in costs for inpatient visits, outpatient visits, and then you look at their medication profile and you scratch your head and you say, how do they have not one single prescription in a 12-month period of time for any of the conditions that they've been coded for inpatient and outpatient visits, right? Low drug adherence rates, you've heard about that, only about 50% adherence rates among all the chronic disease areas, including mental health. Clinical goals, tremendously unmet. 50 to 80% of patients, it's closer to 50% with most conditions like hypertension and diabetes, patients are not at their clinical goals. And then uncoordinated care, which we've developed a whole set of indicators that I'm going to talk about and share with you in terms of it really matters the number of prescribers, the number of physicians that are touching a patient, how many different pharmacies they're accessing for services, particularly avoidable ED and hospital visits, readmissions, and then substance abuse, as you heard earlier, is quite a problem. So how do we actually identify the targets and create these solutions for how we're going to improve quality of care? So what we've spent the last 10 or 12 years doing is developing a methodology for taking claims-based data. Obviously, if you have clinical-based data, that's always good, but 10 years ago, very few people had clinical databases. So we said, well, the best data we have are the payer claims data sets, right? So we developed all of these algorithms that are very sophisticated statistical algorithms, but just to give you a flavor for what are the things that we're looking at when we're looking for identifying an uncoordinated care patient. So some of these look familiar, right? So accessing many different physicians and many different pharmacies concurrently is a real problem that we see in this population. Even if they're assigned to a primary care physician, that's not the physician that they often go and access. ER and chronic care in the, within the ER, they're going to the ER to get what they should be receiving as primary care visits. Duplicative meds and drug services, we actually have algorithms that identify all of that and can cost quantify that. Random drug changes within therapeutic classes. In other words, a patient is what we call drug switching all the time, and I'm going to explain that to you. And then just inconsistent treatment gaps, non-adherence, all these different things that lead to real problems. So what does an uncoordinated care patient look like? How many of you have seen a real uncoordinated care patient? Yes? Sharon raises her hand. Well, we've seen a lot of them, but I thought I'd just show you a couple. So this is a 46-year-old female with cardiac disease, COPD, and depression. And she's been quite busy. She's a full-time patient. 185 prescriptions, 54 different treating physicians touched her in a 12-month period of time, 34 different prescribing physicians, 21 different pharmacies that she was accessing. She obviously has a narcotic seeking issue. She's got 16 different doctors prescribing narcotics for her and doctor shopping at 10 different pharmacies, and 395 medical events or encounters within just the 12-month period of time that we looked at. Now, the last time I checked, there were how many days in a year? 365, right? So, I mean, she is absolutely accessing the healthcare system every single day and probably multiple times a day. So she ended up costing us $36,000 a year. Now that's low, and you might say that number doesn't make sense looking at the number of ER visits that she's had, the number of outpatient and physician claims. But remember that most states have limits on the number of ER visits that they will pay for. They have limits on inpatient days that they'll pay for. So the dollars don't always equate to the utilization numbers that you see, right? Because a lot of it is uncompensated care, and the hospital ends up eating the cost, or the physician eats the cost for it, right? So this patient, though, had she been appropriately managed, should have really cost us about $5,000 or $6,000 a year in drugs and medical services to appropriately manage her, rather than the $36,000 that she ended up costing us. Plus wearing the doctors out, right, that were seeing her. So this is a mental health patient, and this was a young patient with psychoses and schizophrenia. And she received 12 atypical antipsychotic scripts, one each month for a 12-month period of time consecutively. So was she compliant? One script every month for 12 months. Was she compliant? Yes? How compliant was she? 100% compliant, right, with her meds? She took one script every month to treat her schizophrenia, right? But did that mean anything? Because she had $40,000 in inpatient schizophrenia visits, and she had 6 different prescribers prescribing meds for her, and she was taking 4 different drugs, a different drug every month. So from drug A to drug B to drug C, then back to drug B, then to drug D, then back to drug A. She never consecutively took the same atypical antipsychotic 2 months in a row. So 100% compliant in this patient really means nothing, right? We got no utility for the $5,000 we spent in very good antipsychotic drugs. We incurred over $40,000 in unnecessary inpatient visits. So the potential savings for this patient was nearly $40,000, right? So the Institute of Medicine came to us a couple years ago and asked us to take all the methodologies that we had developed and to bounce this against the national healthcare expenditure data sets, and to actually estimate, based on all the work that we had done, what is the true cost of care for uncoordinated care. And we'll provide the white paper for you for this, and there's a direct link to the document as well. But this is a lot of money. This is $240 billion a year. Did anybody think the number would be that high? So if you look at Medicaid and Medicare, it's about $133 billion. In private and commercial, about $106 billion. So this is a staggering amount of money. So I'm going to show you some comparisons from some of the states. This is an example of one of the states that was highlighted in the article. And what we know is that lab, outpatient, ER, pharmacy, physician, inpatient, all of these sectors are impacted by whether a patient has extreme uncoordinated care or much better coordinated care. The average, as you can see, is $15,000 a year in cost for an uncoordinated care patient that was identified in our algorithms versus $3,000 a year in cost for a much better coordinated. They're not 100% coordinated, but they're much better coordinated. So you can see that it impacts every single cost sector. This is an example from Ohio, which is one of the first states that we did extensive analysis on. And what we know is that the extreme uncoordinated care patients that are identified represent only about 10% of patients in the population. And these are straight Medicaid only, these are not dual eligibles. They represented over half of all the prescription costs for the year and over 35% of all the drug and medical costs spent for the Medicaid plan for this population for the year. Now, are these all your high cost, high utilizer patients in this 10%? Shake your head for me. Yes, no. No, because uncoordinated care is not necessarily equated with a super utilizer or a high cost patient. I'm going to show you that. So this was $1.8 billion that just this 10% of the most uncoordinated care patients in their population incurred. And what we know is that 35% of that cost of care was completely avoidable due to duplicative and inappropriate services that were delivered. So the good thing is, every time we look at a state and we map the state, we see essentially the same thing. This was Florida, the first Florida analysis that we did, about 40,000 patients, 7% of their population, very similar numbers, about almost $1 billion here. So the good thing is that the methodology holds up across different populations. This is a slide that looks complicated, but the point of this really is to say, you hear a lot about super utilizers. You heard that term, right? How many people know what that means, right? And high-cost patients. Should we be focusing all of our resources and efforts on that population? Somebody raise your hand. Tell me. Yes? No? You're not sure? Okay. Well, the purpose of this slide is to show you that the answer is no, right? We don't want to focus all of our efforts, because if we did, we'd be focusing on all these people that were in the $50,000 a year, greater than $100,000, $1 million patients who are out here in these two cost groups. So this is their drug and medical cost that they incurred for the year. And so we put them into their individual cost buckets. And that's how much money was spent for the patients in each of those groups. So are there uncoordinated care patients in every one of these cost groups? Yes, right? You see the red bars? Okay. So red bars show us that even $5,000 a year patients, there's uncoordinated care, and there's potential cost savings there, right? As much as any high-cost patient. So this is a deeper dive into the data, saying how can we even further identify the subsets of population where there's actually the cost and quality improvements that we're trying to maximize. Now what's interesting is we have longitudinal data sets where we've looked at 4 or 5 years worth of data. A patient who is down here in the $5,000 a year bucket, but they hit a lot of the criteria for being extremely uncoordinated in their care, where do you think they are the second year, the third year, the fourth year? What do you think happens to them? They what? That's right. And the more you uncoordinate care, the more uncoordinated care you have, and the more cost you have that is avoidable. So if we have a patient here, 3 years later they're here, they're here, they're here, and before long, after several years of extreme uncoordinated care, it just builds upon itself. And so that's why it's important to focus on even a $5,000 a year patient, because if they should only cost you $1,000, there's a $4,000 savings right there, right? If it's a $100,000 a year patient, and they should cost you $90,000 a year, there's a $10,000 a year savings there. But it matters in terms of trying to maximize and differentiate between just your high-cost, high utilizers, who are the people out here in these last two bars. If you can't differentiate these, then you're wasting all your time and resources on people that are not cost and quality impactable. They're just high cost because they're high cost. They're just very sick patients, right? And not all of them, as you can see right here, are cost or quality impactable. So, do we have somebody from Alabama? I saw you on the list. I'm going to pick on you for a minute. So I don't know if you've seen the 25 or 30 page report that was done at the request of the governor's office. But we spent the better part of last year doing an extensive analysis of the Alabama Medicaid claims data. And what we found was very similar to what we found in other states. So we had about 300,000 patients that incurred over $200 million in medical expenses, right? And they had not a single prescription for the year. And these were people that were eligible to obtain prescriptions, right? It wasn't some eligibility group that wasn't able to get drugs. We had 20,000 substance abuse patients that incurred $193 million in costs for the year, almost $10,000 per patient. And they accounted for 40% of all the narcotics that the 1 million member population used for the year. Did you hear me? 20,000 patients used 40% of the narcotics that the whole 1 million member patient population used for the year. So we calculated the savings. It's at least $35 to $40 million a year for them. We had more than 22,000 patients who, as you heard earlier, had more than 8 prescribers. We had patients that had 50 different prescribers. Hard to believe. 500 patients that had more than 40 different drug classes that they were utilizing meds from. Just those 500 patients incurred $26 million a year. That was over $50,000 per patient. Mental health, $247 million were spent on inpatient visits for mental health crisis situations. So we really need to be doing a better job in mental health. And then the interesting part was they asked us to identify the extreme uncoordinated care patients, which we did. There were about 18,000 people. Remember, this is out of a 1 million member Medicaid-only population. There's 2 million members in Alabama Medicaid, but a lot of them are dual eligibles or long-term care patients. And we're only looking at straight Medicaid here. Okay, so 18,000 extreme uncoordinated care patients. Look what they incurred, $800 million, just those 18,000 patients. Okay, and we know that at least 35% of that is cost avoidable. So 6 times the average cost, and we calculated a savings of $166 million a year. Now, when you take all of the issues that we looked at, it was about $389 million that we estimated could be saved. So behavioral health, we'll talk about some cost and care and treatment patterns. You've heard some of this earlier today. The prevalence and comorbidity data in many of the states that we've looked at, it's very similar. State Medicaid programs, as you know, have a prevalence about 15 to 20% for all mental health disorders. Now that's using claims data. Remember, claims data under reports, right? So in some states it might be 30%, it might be 40%, but it depends on how well the ICD-9 codes are being reported into the claims data sets. We know that about 4 to 8% of patients actually have a serious mental illness. And schizophrenia is about 5% of the Medicaid population. Who knows what the prevalence of schizophrenia is in the general population? What is it? Now, of course, 1%. Right, so 5 times the rate. And what's interesting is 60% of them have either a state or federal disability assigned to them. Now, when we look at comorbidities, whether it's schizophrenia, whether it's bipolar, whether it's depression, we see very much higher rates of chronic disease and comorbidities in these populations. Now, you saw numbers closer to 30% for diabetes. That's true if you actually were to screen patients, but remember this is data coming from the claims data set for patients that actually had an outpatient visit and were coded for diabetes. So you can see that it's really a significant problem. The annual cost of care for schizophrenia, bipolar, major depression, as you can see, is like $15,000 to $20,000 a year. These are incredibly expensive patients. If they have more than one mental health condition, it just automatically doubles their cost of care, which is really staggering. The medication treatment data is very disappointing as a pharmacist. It sort of breaks my heart to see numbers like this. We have only 50% of patients who ever got one script in an entire year to treat their schizophrenia. 50%. And those 50% that actually did get a drug, only 20 to 25% of them are what we would consider to be 100% adherent. In other words, they're not changing meds every month like that patient I showed you. They're actually staying on the same med for 10, 11, 12 months out of the year. It's kind of shocking, isn't it? So 40 to 50% are 80% or more adherent. 80% or more adherent is the HEDIS measure that we're all striving to try to attain, but we're falling very short. Those that had less than 80% adherence have huge gaps in their treatment. They have anywhere from 4 to 10 months of gaps, and they're also switching drugs a lot, which is getting us no utility for those drugs. So in states, when you look at the component of inpatient to outpatient, what you see is that, for example, this is a state example, I believe this is Florida, $67 million was spent on inpatient visits for mental health schizophrenia coded services. So 70%, 30% spent on outpatient. But here's the really interesting part. Only 35% of the patients, and there were 10 or 11,000 of them that had inpatient visits, only 35% of them accounted for all of the hospital stays and all of the cost. So that's incredible if you think about it. So if you're depressed and think, how can we possibly overcome these hurdles? Well, there's your answer. We don't have to manage all 12,000 patients. We only have to manage these 4,800 patients to get nearly $50 million in savings, right? So drilling the data and drilling the data and drilling the data gets you down to who's your interventional subset of the population where you need to spend your resources. Uncoordinated care cost savings for schizophrenia. We've been talking about schizophrenia in general in the previous slides, right? But what about the uncoordinated care schizophrenia patients? They represent 30 to 40% of the schizophrenia population, right? So it's not 100% of schizophrenia patients that we have to intensively manage. It's only these 30 or 40% that have all the uncoordinated care. They accounted for over 50% of all the mental health costs for the population for the year. And, you know, the potential savings here is like $20,000 per patient. So this is an example to show you when we have coordinated care patients in blue, who are the ones that are more than 80% adherent on their medications, versus the uncoordinated care patients here in red. They not only are uncoordinated in meeting all of the criteria for uncoordinated care, they also are non-adherent and they're switching meds all the time. And I want you to look at the differences here. Their average schizophrenia hospital cost difference is $20,000 a year just for schizophrenia inpatient cost. $20,000 a year versus $2,200 a year. Their total schizophrenia costs were $23,000, which tells you that almost all of their schizophrenia costs were inpatient visits, right? $20,000 is a subset of the $23,000 they spent on all their schizophrenia coded visits. And when you look at here, this is all their mental health care costs. So they not only had schizophrenia, they obviously had some other mental health issues. But this is really staggering when you think about the cost savings that can be generated on a per patient basis if we identify and target the right subset of the population. So how do we ensure continuity of care, access, and adherence to treatment? Most of you here from the industry are pretty familiar with all the biomedical innovations. We've had a lot of new drugs developed in the last 10 or 15 years. They have lower side effect profiles, they have easier dosing schedules, they have increased safety profiles, they're genetically targeted technologies, and that's important because these patients are very complex. They have a lot of complex comorbid conditions, and we really need a lot of options to be available for them for treatment. And we need them to take their drugs, right? The best drugs in the world don't work unless you take them. So there's quite a bit of published data. I'm not going to spend too much time on this, but it basically shows you there's probably 20 studies. California, Wisconsin, Virginia are 3 that I pulled up here for you, so that you can see when we discontinue drugs and when we have reduced access and gaps in treatment for whatever reason, we have 3 to 4 times increased risk of hospitalizations and cost and longer stays. So what are the factors that reduce adherence? Adherence to medications is caused by a lot of different reasons, but particularly in the Medicaid population, we see that drug switching due to uncoordinated care, meaning that they're seeing so many different physicians and accessing so many different clinics for their care, and there's really no continuity of care, that creates a big problem. Formulary changes, lack of formulary continuity between an inpatient and outpatient setting. As you heard earlier, what happens when a patient goes in for an inpatient stay, they get stabilized on a particular medication, they come out, and then suddenly that drug isn't covered. And if it's not covered, then there could be delays in treatment. Sometimes 30, 40% of the time they never even get their med refilled because they're having problems getting approval. So these are big issues, as well as differences in the Medicaid managed care world. Remember, Medicaid patients move around quite a bit, right? So let's say 6 months out of the year they're in Plan A, then they move to Plan B. What happens if all their meds have to be changed? You know, that can tremendously impact adherence. Who knows what a differential copay is? Yes? So differential copays are pretty common in most health plans, where you pay one copay for a generic versus one copay for a brand. And when you're paying differences, sometimes in Medicaid it's not so much different. Sometimes it's $1 for generic versus maybe $3 for a brand. But in other commercial plans it can be a few dollars for a generic and then $25 or $30 or $40, or even a portion of the cost that's actually a co-insurance cost for the brand name drugs. So there's a lot of studies to show that definitely high differentials in copay structures can impact adherence. Complicated regimens. How many of you like take 1 pill a day, right? You want to take 3 pills a day instead of 1 pill a day? I can't even remember to take 1 pill a day. I don't know about you. Side effects and adverse events and forgetfulness. Did anyone forget to take your medication this morning? Come on, raise your hand. I did. I forgot. I'm terrible. And I know all the right things to do, right? So forgetfulness and lack of knowledge and counseling patients is really important. So what are all the things we can do to improve adherence? Care coordination is very critical. Having continuity of care between inpatient and outpatient settings and among health plans is very important once we have a patient stabilized on a medication. Simplified dosing regimens, medications with lower side effect profiles always improve adherence. Enhance patient knowledge through counseling. I mean, who's the right person to actually counsel a patient, right, about taking their medications, the importance of doing that? So clinical pharmacists have begun to take on a significant role in doing this, both one-on-one with the patient as well as communicating with the medical home and the health home nurse case managers and trying to help fill that gap for really getting patients adherent on their meds and tracking their meds to see that they are adherent. So there are some policy things that can be done. Auto refills, refill reminders that pharmacies can do. Dispensing a 90-day supply, we know from a number of studies that have been published, actually giving someone a 90-day supply of their chronic medication increases their adherence rates up to 20%, which you might say, well, that's really not that much. But think about it, if you're only at 70% or 80% adherence and we increase your adherence by 20%, that's a big deal. So there are lots of things that we can do as policymakers to think through improving adherence. So what are some of the quantitative and qualitative measures? You heard earlier, what are the things that we want to measure? Utilization and cost measures. When we do an analysis for a health plan, we will look longitudinally over 12 to 24 months, and there are lots of things that we can see in the claims data. We can see whether there have been reductions in duplicative therapies for particular patients that might have undergone an interventional strategy. We can see reductions in inappropriate narcotic use and unnecessary drugs. We can see reductions in gaps in treatment and increases in clinical-based adherence rates. We can see reductions in drug switching. We can see all of this in the claims data. We don't have to have access to clinical data, right, from the physician's office. We can see all this in the claims data from the payer. So we can see reductions in admission and readmission rates, and then, of course, reductions in total PM cost as well, which is the ultimate goal for those patients that have opportunities. Quality measures, you heard earlier, improved clinical endpoints is very important. How do we get people to the right hemoglobin A1Cs, the right blood pressure, right lipid levels? How do we determine that rates of appropriate labs have been ordered at the appropriate time intervals? So not 3 doctors ordering a hemoglobin A1C at 3 different times for a patient in a 3-month period of time, right? Is that wasteful? It's wasteful, but guess what it tells you? That you're 100% HEDIS compliance with that measure. But is that what we really want? 3 different doctors ordering 3 different lab tests for the same patient? No. So improved mental and physical functional status is important. Medication consistency, reconciling meds as a patient moves in and out of the hospital, improve compliance in HEDIS measures as long as they're meaningful measures, and then looking at other NQF quality measures that are out there as well. So what are the next steps? The next steps for success really is we would sit down with a health plan or a state agency and say, and this is applicable not just to the Medicaid population, this can be your state employee population, this can be a commercial population. All these analytics hold up in terms of the methodology being applied to any claims data set. So independent and ongoing claims-based evaluations are really important because we need to determine the baseline. If you don't know where you are, how do you know where to start, right? Does that make sense? So we need to collect the baseline, we need to establish the baseline, and then we need to create standard reporting measures for what we're going to actually measure. We need to integrate physical and behavioral health care, as you heard earlier today, integrate new models of care, manage patients now. So don't wait to manage people, let's manage them now. Quarterly evaluations are very important for knowing whether you're actually intervening in an appropriate way and whether you're creating those changes in the baseline that you want to see. And then supporting care models that actually create incentives like what you heard about this morning. Incentives for physicians and provider networks to actually target these groups of patients. And then, importantly, engage in partnerships with common goals. Providing technical assistance and other support is real important. How many of you have heard about the new NGA super utilizer grants that have been issued? Okay. So is Wisconsin here? Did you know you have one? You received one? One of only 6 in the nation. Puerto Rico, are you here? I know we have somebody from Puerto Rico. Yes. Well, they were one to receive. Who else? Does anybody else know that you got one? Kentucky, raise your hand. Kentucky got one. West Virginia got one. Alaska, anybody here from Alaska? Did you know you won one? You did? Well, there you go. So my concern is that these 6 grants have been given through a Robert Wood Johnson Foundation to do what's called a super utilizer analysis. But my concern is, based on what I showed you, is that really the only methodology that you need to apply to a claims-based analysis in your project, right? So you not only care about the high utilizers, perhaps, you care about the ones of them that are cost and quality impactable, right? You don't just care that they have a high rate of ED visits or that they have high inpatient expenditures, because some of them might not be avoidable, right? So a much more sophisticated approach to the data is to figure out what subset of the subset of patients are the ones that we need to target. Public policy actions for you to think about today. How do we facilitate these partnerships with the payors, with the providers, private sector? We need to figure out and identify who these targets are, and then we've got to work together to figure out the real solutions. So anything that you can do legislatively or in a policy arena that helps you actually support policies that get providers to work together in a meaningful way and actually can measure their success rates and reward them, not just in a fee-for-service environment, but reward them for attaining the savings and the quality and utilization improvements is what's really important. So facilitating all types of providers, as you heard, an interdisciplinary approach. We know that is the best approach. Physician can't do it all, nurse can't do it all, pharmacist can't do it all. We all have to be working in a team, and we have to assign roles appropriately in order to do that. So I just gave you a list here to finish up on who are the stakeholders, who are all the partners that you should be working with, state Medicaid agencies, federal agencies, employee commercial plans, professional societies, safety and quality and advocacy groups can play a very significant role, and then of course all of your supporting organizations that help you. So I'll leave it there and leave time for the other presenter. Thank you.